Safety guidelines. Hospitals and research labs' ASIAN protection requires a systematic program covering all modalities: diagnostic X-ray, CT, fluoroscopy, nuclear medicine, radiotherapy, and research sources, sealed, unsealed radionuclides, particle accelerators. Key principles are justification, only approved procedures, optimization ALARA, doses as low as reasonably achievable, and compliance with dose limits. Facilities must implement engineered barriers, shielding, containment ventilation, interlocks, warning signs, and administrative controls, access restrictions, SOPs, training, waste handling to maintain exposures below regulatory limits. Routine monitoring, personal dosimeters, area surveys, contamination checks, and strict record keeping ensure compliance. Emergency plans must cover spills, overexposures, and lost sources with prompt incident reporting. Adequate medical surveillance, health exams, pregnancy monitoring, and periodic training keep workers informed and competent. Scope and applicability. These guidelines apply to all ionizing radiation uses in hospitals and laboratories, diagnostic radiology, including dental, interventional and image-guided procedures, nuclear medicine, radiotherapy, and research, academic, industrial, involving sealed or unsealed sources and radiation generators. They encompass X-ray equipment, CT, C-arm fluoroscopy units, linear accelerators, cyclotrons, isotope labs, e.g. 99 MEMTC 131I, particle irradiators, and labs handling radioisotopes or radionuclides. Staff covered include imaging technologists, physicians, physicists, nurses, researchers, and support personnel. Key principles: ALARA, justification, dose limits. Justification. Every procedure must be justified by clinical or research benefit outweighing radiation risk. Unnecessary imaging or experiments are avoided. Clinical protocols, e.g. imaging referrals, and research proposals undergo review to confirm justification. Optimization, ALARA. After justification, protection is optimized so that exposures are as low as reasonably achievable, economic and social factors having been taken into account. Practical measures, time, distance, shielding, collimation, dose modulation are used. Protocols like diagnostic reference levels guide imaging dose reduction, especially in pediatrics. Dose limits. Regulatory dose limits, protective ceilings must not be exceeded by routine exposure. For occupational workers 18Y, the ICRP-IE recommend 20 millicis per year, average over 5 years. The US NRC limit is 50 millicis per year, 5 rem. Equivalent dose limits for organs: lens of eye, 20 millicis per year, ICRP, 150 millicis for US, extremity skin, 500 millicis V also apply. For the public, the typical limit is 1 millicis per year. Medical patient exposures are not counted against occupational limits, and no dose limits apply to patient care. See table below for comparison of typical values. Exposure limit ICRP IAA annual, US NRC annual, effective dose occupational 20 millicis VOV, 50 millicis V, 5 rem. Lens of eye, occupational 20 millicis V, 150 millicis V, 15 rem. Skin extremities, occupational 500 millicis vol, 500 millicis vol, 50 rem. Effective dose, public 1 millicis vol, 1 millicis V, 100 millirem. Engineering controls. Effective shielding and containment are the first line of defense. All facilities must meet design standards for radiation containment. Shielding design. Walls, ceilings, floors, and control booths for X-ray and therapy rooms use lead, concrete, or other approved materials sized for the equipment's workload and energy. Calculations must consider adjacent occupancy. Accelerators, high-energy X or particle beams, require special structural shielding and interlocks. Cabinets or lead bricks may be used for storing active sources. Shielded transport containers are used when moving sources. Containment for unsealed sources. Labs and radiopharmacies handling radioactive liquids, powders, or gases must have non-porous, easily decontaminated surfaces. Work with volatile radionuclides, e.g. 131I, 99 METC aerosols, is done in ventilated hoods or glove boxes with HEPA charcoal filtration. Rooms handling radionuclide preparations are kept at negative pressure relative to adjacent areas. Ventilation exhaust is filtered or directed to safe zones, never recirculated. Signage and labeling. Entryways to radiation areas, controlled areas, or radioactive materials areas must display standard warning signs, trefoil symbol, and controlling instructions. Lab equipment and waste containers must be labeled with radioisotope identity and activity. Safety interlocks, emergency shutoffs, and exit routes are clearly marked. Power and ventilation systems incorporate alarms or override controls as needed, e.g. ventilation fail alarms. Administrative controls. Strong administrative measures supplement engineering features. Training and authorization. Only qualified personnel are authorized to use radiation. New staff undergo radiation safety orientation before any exposure. Refresher training is provided at regular intervals, typically annually, or when procedures change. Training covers ALARA concepts, regulations, safe handling, emergency procedures, and use of protective gear. Regulatory bodies, e.g. U.S. NRC, often require documented instruction to anyone likely to exceed even 1 millisieverts per year. Competency is assessed by tests and observations. Retraining occurs if needed. Access control. Controlled and supervised areas are designated by personnel monitoring and exposure risk. Access is limited to trained staff. Entry logs may be kept. Pregnancy must be declared so fetal dose can be limited. Occupational fetal limit usually 5 millisieverts over term. Standard operating procedures SOPs. Written SOPs cover normal operations. Equipment startup shutdown, source handling, alignment checks, waste disposal, and decontamination. Procedures are approved by the Radiation Safety Officer, RSO, or committee. SOPs include administrative action levels, e.g. investigation levels at fractions of dose limits, to trigger reviews. Work permits or checklists may be used for high-risk tasks, radioisotope experiments, isotope shipment, entry to accelerator vault. Waste management. Radioactive waste, solid, liquid, gas, is segregated by half-life and isotope. Short-lived waste is held for decay in shielded containers. Decay in storage. Long-lived waste is processed per regulations, transferred to licensed disposal, decay tanks, etc. Consumables contaminated with radioactivity are bagged and stored as low-level waste. Transport of radionuclides follows national and IAEA regulations, proper labeling, packaging, training. Record keeping and audits. The facility maintains records of training, equipment calibration, radiation surveys, source inventories, personnel doses, incidents, and waste disposals. Internal audits of compliance and ALARA reviews are conducted periodically, e.g. annually, to identify and correct safety gaps. The regulatory authority may require formal reports of any event, spill, overexposure, lost source, exceeding reportable thresholds. Monitoring and instrumentation. Ongoing measurements ensure that controls are effective. Personal dosimetry. All radiation workers wear individual dosimeters, film, TLD, or electronic, when expected doses exceed a few millisieverts per day. Dosimeters are exchanged and read by accredited labs. Records are maintained. Extremity dosimeters are used for high hands exposure, interventionalists, brachytherapy, as needed. Area monitors. Fixed detectors in high-use rooms, e.g. therapy vaults, hot labs, provide real-time dose rate information. Portable survey meters, Geiger counters, ion chambers, scintillation detectors are used for routine area surveys and after-source operations. Workplaces are checked daily or weekly by RSO staff to verify controlled area boundaries and ALARA. Contamination surveys. Wipe tests are conducted regularly in radionuclide labs, benchtops, floors, equipment to detect surface contamination. Airborne contamination may be checked after suspected releases. Continuous air monitors and grab samples detect ventilation leaks. After decontamination, surveys ensure activity levels meet background or clearance criteria. Calibration and quality control. All radiation measurement instruments and imaging devices undergo periodic calibration by accredited services. X-ray machines, CT scanners, and nuclear medicine cameras have routine QC, beam output, uniformity, well counter efficiency, etc. to ensure dose accuracy and detect malfunctions. Radiation surveys and dosimeter readings are traceable to standards. Emergency response and incident reporting. Preparedness and rapid response minimize harm from accidents. Incident procedures. Written plans cover spills of radioisotopes, overexposure incidents, contamination events, and lost sources. In any incident, the priority is isolating hazards and protecting people. Stop the exposure, evacuate or cordon the area, and secure radioactive materials. Personnel immediately notify the RSO, supervisor, or emergency team. The RSO supervises dose measurements and directs decontamination. Spill and contamination. A spill kit, absorbents PPE, radiation signs, is available in each radioactive lab. Personnel trained in spill cleanup, wearing gloves, lab coat, respirator if needed, cover spills with absorbent, scoop loose material into shielded containers, and survey for residual contamination. Contaminated materials and PPE are disposed of as radio waste. Overexposure. If a worker's dosimeter shows a dose above operational levels or dose limit, the event is investigated immediately. The individual is interviewed for possible unrecorded exposures, e.g., unlabeled source. Unexplained dose excess may trigger bioassays or medical evaluation. All such events are reported to regulatory authorities. Lost or stolen sources. Misplacement of a source triggers immediate search and secure actions. If not found quickly, authorities, police, radiological emergency responders are alerted to prevent inadvertent exposure. Incident reporting. Formal reports are filed with the regulatory body for any event involving overexposure, contamination release, or lost abandoned source. Incident records include root cause analysis and corrective actions to prevent recurrence. Flowchart TDA suspected radiation incident B, notify radiation safety officer. B, C, secure area and halt operations. C, assess situation, radiation and contamination levels. Contamination? Yes. F, decontaminate person surfaces. No. G, document findings. F, medical evaluation and dose assessment. H, I, report to authorities and record incident. J, review and strengthen controls. Flowchart, steps for incident response, from detection through reporting. Medical surveillance and occupational health. Radiation workers should receive appropriate medical oversight, a baseline health exam at program entry, and periodic follow-ups as dictated by dose levels and age, often annually or biennially. Specific surveillance may include vision exams for interventionalists, skin checks, and blood tests for internal contamination. Women must declare pregnancy to switch to fetal dose monitoring, and a pregnancy limit, commonly 5 minutes SV over gestation. Workers handling biohazards or chemicals should have combined health programs. All occupational exposures and any health effects are confidentially recorded with provisions for worker notification and compensation per law. Regulatory compliance and record-keeping facilities must meet national and international standards, e.g. IAEA ICRP recommendations, and local regulations. Key compliance elements include authorizations. Equipment and radioactive materials are licensed or registered as required. The RSO ensures regulatory limits for effluents, waste, and exposure are respected. The facility obtains necessary transport permits for radioactive shipments. Documentation. Exposure records, dosimetry reports, training logs, audits, incident reports, and annual compliance reports are maintained for regulatory review. Equipment and source inventories are tracked. Periodic audits to detect missing sources. The RSO or equivalent typically submits yearly program summaries, e.g., doses, incidents, inspections to authorities. Inspections. Government bodies may audit the radiation program, inspect shielding and warning signs, and verify SOPs and training. Findings are promptly addressed. Continuous compliance is ensured by embedding a culture of safety, training frequency, and competency assessment. Training is not a one-time event. Regulations stipulate instruction before occupational exposure and at least annually thereafter. Training content is tailored to tasks, e.g. imaging versus radiopharmacy, and updated for new equipment or procedures. Competency is checked by quiz or practical demonstration. For research labs, training covers safe handling of unsealed, sealed sources, and emergency drill participation. Records of training completion and competency tests are kept in personnel files. Checklists, daily, monthly, annual. Daily, verify area monitors, warning lights, and alarms. Check that shielding barriers and interlocks are functioning. Survey work areas for contamination, wipe tests for hot labs. Ensure personal dosimeters are worn and functioning. Confirm proper signage is in place. Monthly, review dose records for ALARA trends. Conduct mock spill drills. Calibrate portable survey meters. Inspect waste storage and inventory. Test emergency power and ventilation backups. Hold safety meeting to review any issues. Annually, perform full program audit, dosimetry analysis, training adequacy, equipment QC. Verify source inventories, sealed source leak tests, count sources. Update SOPs and training materials. Review and renew licenses registrations. Sources, authoritative standards, and guides have been synthesized, including IAEA safety standards and NRC ICRP recommendations. 1, 5, 7, 20, 13, 15, 3, 18, 12, 11. These cover international best practices for radiation protection in medical and research settings.